Growth hormone releasing hormone increases growth hormone secretion, whereas ghrelin, GHRELEN, growth hormone releasing, so this also increases growth hormone secretion. Whereas growth hormone inhibitory hormone, which is otherwise called as somatostatin, decreases growth hormone secretion. As the name itself indicates, somatostat. Stat means stop. It is static to somat. Somat means body growth. It decreases growth hormone secretion. And the other action of growth hormone, inhibitory hormone, somatostatin, it is static to in. In means insulin. So it is static to insulin also, decreases insulin secretion. It is static to somat. Somat means body growth. So two important actions of somatostatin. It decreases growth hormone. It decreases insulin also. That's why the name somatostatin. What are the hormones which have effect on growth? Other than growth hormone is necessary for growth during the entire period of life. From birth until you complete your adolescent growth, growth hormone is important. What are the other hormones which help you in growth? Thyroid hormones, especially during the initial few years of life, 1 or 2 years. Neonatal growth, thyroid hormone is very important. That is why congenital hypothyroidism, cretinism, one of the presenting feature is dwarfism. Cretin babies are dwarf. Their growth is stunted. Androgens, as the name indicates, sex hormones, they are especially active during the adolescent growth. The adolescent spurt of growth is because of androgens and estrogens, your sex hormones. So we understand that other than growth hormone, thyroid hormones and androgens, your sex hormones, estrogens also help you to increase the growth. What are the actions of growth hormone in 2 stages of life? Before fusion of epiphysis and after fusion of epiphysis. Before fusion of epiphysis, that means your bones have not yet fused in a child. Since the bones have not yet fused, this growth hormone helps in increasing the growth of cartilage cells. Chondrogenesis, it increases chondrogenesis. That is why the height of a child can increase because of growth hormone. And that's the reason excessive levels of growth hormone in a child results in gigantism. The height of the child is more, gigantism. After fusion of epiphysis, what is the action of growth hormone? Once the bones have fused, it can no longer increase the height because cartilage cells cannot grow because the bones have fused. But other than the height, it will start increasing the other factors. What are they? Increases the size of soft tissue, organs, organomegaly, jaws and brows increase in size, hands and feet increase in size. And that is why excessive levels of growth hormone in adults after fusion of epiphysis results in acromegaly. What are the features of acromegaly? Increase soft tissue, organomegaly, prognathism, projection of jaw, eyebrows protrude, hands and feet are bigger in size. So that is about the features of acromegaly. That's also the difference between gigantism and acromegaly. What are the other actions of growth hormone? All actions of growth hormone are related to growth only. So you just remember, growth hormone enhances growth in all other ways. What are the other actions? For growth, you need proteins. So growth hormone increases protein synthesis. For growth, you need electrolytes. So growth hormone decreases the excretion of electrolytes in the kidney and takes all this electrolyte into the growing tissues to increase the growth. For growth, you need energy. Growth hormone gets energy from fats. Fats are broken down. That is called lipolysis. When fats are broken down, they produce ketone bodies. That's called the ketogenic effect of growth hormone. So growth hormone is ketogenic. It will use fats for energy, but growth hormone never utilizes carbohydrate for energy. Carbohydrate, the raw material is glucose. So blood glucose is never utilized by the cells. If cells are not taking up the glucose, blood level of glucose increases. This results in hyperglycemia. So growth hormone is ketogenic, growth hormone is hyperglycemic. What are the factors which affect growth hormone secretion? What are the factors which increase growth hormone secretion? Growth hormone is hyperglycemic. It means growth hormone increases the levels of blood glucose. Therefore, any factor which decreases the level of blood glucose will increase growth hormone. All hypoglycemic factors, what are they? Fasting, starvation, exercise increases growth hormone. Glucagon is a hormone which is increased during the levels of fasting. Thyroid hormones and androgens, we already saw. Thyroid hormones and androgens also increase growth. ADH, antidiuretic hormone. What is the action of ADH? Water reabsorption. So you remember like this, for growth you need water. So ADH increases growth hormone. Increased amino acids, because growth hormone can convert all these amino acids into proteins, because growth hormone increases protein synthesis. So these are the factors which increase growth hormone secretion. What are the factors which decrease growth hormone secretion? All hyperglycemic factors. When your blood glucose levels are high, growth hormone is not needed, so the levels are low. What are the hyperglycemic factors? Cortisol, glucose itself. Just if you infuse glucose into a patient, it's called the glucose infusion test. Just by infusing glucose into the patient, if it is a normal patient, growth hormone level will decrease. But if it's an acromegaly patient, what is acromegaly? Pathologically, so much excess of growth hormone is called acromegaly. In an acromegaly patient, he has so much of growth hormone levels that even if you give glucose, growth hormone levels are not decreasing. Still it is high. So even after infusion of glucose, if growth hormone levels are still high, then you diagnose the patients with acromegaly. That's called the glucose infusion test. Somatostatin, already we saw. Static to somat. Somat means growth hormone. It decreases growth hormone levels. What are the disorders, clinical disorders related to growth hormone? In children, excessive growth hormone causes gigantism. In adults, excessive growth hormone causes acromegaly. Growth hormone deficiency. In children, dwarfism. In adults, an adult cannot become a dwarf again. So instead of height, it starts acting on blood glucose levels. Growth hormone increases blood glucose. So growth hormone deficiency decreases blood glucose. Hypoglycemia in adults. A special form of dwarfism, Laron dwarfism, identified in world's shortest tribal people, African pygmies. What is Laron dwarfism? The problem here is either there is problem with the receptors for growth hormone, receptor insensitivity, or there is something wrong with somatomedin C. What is somatomedin C? Somatomedin C, this is an important factor which is responsible for growth. Growth hormone, generally it enters into the liver, converted into somatomedin C, which is otherwise called insulin-like growth factor 1. And this somatomedin C only is responsible for most of the growth effects of growth hormone. So if a patient has something wrong with somatomedin C, these group of people, African pygmies, they have a genetic defect in somatomedin C. That's why even though their growth hormone levels are normal, they are dwarf because there's mutation of somatomedin C. So somatomedin, don't confuse somatostatin and somatomedin. Somatostatin, stat means static, it will stop growth hormone. But somatomedin, med means it will mediate growth hormone action. It will mediate the effects of growth. So somatostatin is static to growth, but somatomedin mediates growth. So that was about Laron dwarfism. Over to second question from CNS. Purkinje cells are found in. Once it was an image based questions also where a histology image of Purkinje cell was given. Okay, so the answer is cerebellum. Where are Purkinje cells present? They are also present in the cerebral cortex, but they are the most important cells of cerebellum. Cerebellum. This is the location of cerebellum. Cerebellum is located somewhere here between the motor cortex on top and all other parts of the body below. What is the importance of this? Cerebellum gets all the planning from the motor cortex and all movements from all parts of the body below. It will coordinate the plan with the movement. That is why cerebellum is called coordinator of the body. Any problem with cerebellum, the patient will present with incoordination. The medical term for incoordination is ataxia. So cerebellar disease results in cerebellar ataxia. What are the different parts of the cerebellum? Cerebellum has a cerebrocerebellum. The lateral portions are called cerebrocerebellum. Cerebrocerebellum is responsible for planning. It gets the plan from the motor cortex. The medial portions are called as spinocerebellum. Why is it called spinocerebellum? Because it connects to the spinal cord and from there to the muscles and helps in coordination of the body. That's why it is called the spinocerebellum. Vermis is the centermost part of the spinocerebellum. So it controls the coordination of centermost muscles of the body. What are the centermost muscles of the body? Your trunk muscle. It helps in trunk muscle coordination. Vestibulocerebellum. Anything related to vestibular apparatus means balance and equilibrium. If you are able to maintain balance and equilibrium, you can maintain your gait. Gait means the way you walk is called as your gait. Vestibulocerebellum is made up of nodulus and flocculus. That's why the name flocculonodular lobe. Nodulus and flocculus are related to eye movements. That's why they help in vestibulo-ocular reflex, otherwise called the doll's eye movement. What is doll's eye movement? Have you seen the eyeballs of a doll? If you rotate the head to one side, eyeball will go to the opposite side. That's called the doll's eye movement. What are the different type of cells present in the cerebellar cortex? There are 5 different cells in the cerebellar cortex: Purkinje cell, granule cell, Golgi cell, stellate cell, and basket cell. These are the different types of cells present in the cerebellar cortex. Deep into the cerebellum, there are 4 different nuclei. What are the 4 deep nucleus? The mnemonic is doctors eat good food. Actually no, but the mnemonic is doctors eat good food. DEGF. From outer to inner, the nucleus are dentate, emboliform, globose, and fastigial. From outer to inner, dentate, emboliform, globose, and fastigial. So these are the different parts of the cerebellum. What are the diseases related to cerebellum? Let's learn about the connections of the the disorders related to cerebellum. Once we know the parts of the cerebellum, then disorder becomes very simple. Cerebrocerebellum, planning. So if there is something wrong with the cerebrocerebellum, planning is affected. This is called delay in initiating movement. Vestibulocerebellum related to balance and equilibrium. So if something is wrong with this disequilibrium and eyeball movements are affected, that is called nystagmus. Spinocerebellum. Spinocerebellum is related to coordination. So if anything is wrong with spinocerebellum, this results in incoordination. Incoordination is called as ataxia. So important feature of cerebellar dysfunction, incoordination or ataxia. What are the different forms of incoordination or ataxia? Incoordination of distance is called dysmetria. Meter means distance. Intentional tremor. Dysdiadochokinesia. Incoordination in doing alternate movements is dysdiadochokinesia. Dysarthria. Incoordinated speech is called dysarthria. And rebound phenomena. You ask the patient to flex the elbow like this and you give resistance in the opposite direction. Suddenly, if you remove your hands, he will hit on his face. This is called rebound phenomena. All these are disorders related to cerebellum. And please remember, cerebellar disorder results in intentional tremor. It means intentionally, if the patient wants to do any activity, there is tremor. This is called intentional tremor. This is in contrast to resting tremor, which is seen in Parkinsonism. Parkinsonism disease patients, they have a problem with resting state itself. When they are in rest itself, there is a tremor. That is called resting tremor. So this was the histology image of the Purkinje cell. How will you identify the cells? They are the largest cells of the cerebellum, and their dendrites give a wide diffuse dendritic connection. So if you see multiple dendritic connections like this, then it is a Purkinje cell of the cerebellum. Third question from GIT. Brunner's glands are found in. What is this Brunner's gland? So Brunner's glands, they are present in the duodenum. They are a part of the duodenum. And Brunner's gland secretions have a pH of about 8 to 8.9. It means they are the most alkaline secretions. Why Brunner's gland secretions are most alkaline? Why a duodenal gland secretion should be more alkaline? The duodenum is receiving the acid-rich food from the stomach. So only if it is highly alkaline, it can neutralize this acid. Otherwise, the patient will develop duodenal ulcers. In order to prevent duodenal ulcers only, the duodenal gland secretions, Brunner's gland secretions, are the most alkaline secretions. So Brunner's glands are found in duodenum, the most alkaline secretions. Question number 4. During which phase of menstrual cycle are progesterone levels highest? So the question is about the progesterone levels. So in order to understand this, let's have a quick recap of the menstrual cycle and also oogenesis. So only then it will help you to better understand this question. A quick recap of oogenesis. Oogenesis starts from 15th week of gestation itself. It means even before the birth of a female baby, oogenesis begins. The primordial follicle development starts around 15th week of gestation. Around 28 weeks of gestation, meiosis 1 begins. It means meiosis 1 has started, but it is arrested in prophase 1 itself. It stops there. It stops in prophase 1. Now the girl baby is born. At the birth of a girl baby, the ovary has around 4 lakh primordial follicles. From this 4 lakh primordial follicle, after puberty of the baby, every month, it means the girl baby, she has grown up and attained puberty, every month one primordial follicle is selected and it is converted into a Graafian follicle. Graafian follicle contains the primary oocyte inside. So that is what we call as menstrual cycle. What is happening every month during menstrual cycle? From the 4 lakh primordial follicle, one primordial follicle is selected, converted into Graafian follicle. And this Graafian follicle contains the primary oocyte inside. Just before ovulation, the primary oocyte completes meiosis 1. This meiosis 1 was started at around 28th week of gestation, but it was arrested. Now when it is resuming back just before ovulation, primary oocyte completes that meiosis 1 which was started in the 28th week. And this results in the formation of secondary oocyte. This results in the formation of secondary oocyte and first polar body. This secondary oocyte on ovulation released. It is released. That is called ovulation. So what is ovulation? Release of the secondary oocyte. And after release of this secondary oocyte, if there is a sperm waiting there, if intercourse has happened and this is a sperm waiting there, secondary oocyte fertilizes with this sperm to undergo fertilization, and now it completes meiosis 2 to form fertilized ovum and a second polar body. So this is the complete process of oogenesis. Now every month during menstrual cycle, what happens? One primordial follicle is selected, converted into Graafian follicle. So this primordial follicle is converted into Graafian follicle, and that is why the initial first 14 days is called as follicular phase, because there is formation of The Graafian follicle, a follicle is being formed. That's why the first 14 days is called as follicular phase. And the hormone responsible for this is obviously follicle stimulating hormone. If you want to form the follicle, it's called follicular phase, and the hormone is follicle stimulating hormone. So what happens during the first 14 days of the menstrual cycle? So this is the first 14 days, and then you have the last 14 days. So what are the changes that happen? During the first 14 days, there's follicular phase because follicle is being formed, and the hormonal changes FSH. On the 14th day, exactly on the 14th day, what happens? This Graafian follicle ruptures. When the Graafian follicle ruptures, this is called ovulation. The hormone responsible for ovulation. Just before ovulation, you call it as the LH surge. In the menstrual cycle, on the 14th day exactly, there is ovulation. Just before ovulation, there is LH surge. LH surge means luteinizing hormone level increases. This further increases estrogen. Estrogen increases LH. Again, LH increases estrogen. This is called the positive feedback loop of LH surge. And exactly on the 14th day, ovulation. This Graafian follicle has ruptured. What is the fate of this Graafian follicle? The ruptured Graafian follicle, the secondary oocyte is released. But what is the fate of this follicle? This follicle is converted into a corpus luteum. That is why the last 14 days of the menstrual cycle is called luteal phase, because there is formation of corpus luteum. Corpus luteum begins to produce the hormone progesterone. So the hormone that is increasing during the last 14 days is progesterone. And this corpus luteum, if fertilization happens, it will be converted into corpus luteum of pregnancy. If no fertilization happens, so this is formed as corpus albicans, and this corpus albicans is a scar tissue which is remaining inside your ovary. So this is the outline of the menstrual cycle. And to give you exactly the phases of the menstrual cycle, first let's see what are the ovarian changes. What are the ovarian changes? This is day 1, and this is day 14, and this is day not 23, so this is 28 in a normal 28-day cycle. Yes. So the first 14 days and the last 14 days, and on the 14th day there is ovulation. This is exactly the 14th day. In the ovaries, first 14 days, it is called follicular phase because a follicle is being formed. The next 14 days is called luteal phase. On the 14th day, ovulation. What is the hormonal change? First 14 days, FSH increases. Yes, if a follicle is being formed, follicle stimulating hormone increases. And just before ovulation, LH increases. A further increase in LH causes increase in estrogen. That is the LH surge. What is the hormonal change during the last 14 days? Corpus luteum begins to produce progesterone. So progesterone levels are increasing. Now over to uterus. We saw the ovarian changes and hormonal changes. What are the uterine changes? Inside the uterus, first 5 days there is bleeding. That is a menstrual bleeding, periods, menstrual phase. And from the 6th day onwards, in order to recover from this bleeding, all the endometrial cells have been shed away in bleeding. In order to recover from this, the uterus has to proliferate because it has lost its cells. So it will start to recover from this by proliferating. So that's why 6 to 14 days proliferative phase. Immediately after menstrual bleeding, you have proliferation. And the last 14 days, the uterus, all the glands become very tortuous, they increase in size and they begin to produce secretions. That's why this phase is called secretory phase. So in the uterus, first 5 days bleeding phase, next 6 to 14 day proliferative phase, 14th to 28th day, this is the secretory phase. These are the uterine changes. So that was a quick review of menstrual cycle. Over to the question. I think now the question will and the answer also will be very clear to you. During which phase of menstrual cycle are progesterone levels highest? Yes, after ovulation. The last 14 days, progesterone levels are highest, which means between ovulation and the next menstrual bleeding. Question number 5. Which of the following is true about secondary active transport? What are the different types of transport mechanisms? So we have already learned this with the help of a person who is climbing the mountain. So just listen to this. First we'll do active transport. Just imagine you are going to climb a mountain. You have to go against the concentration gradient because you have to climb from low to high. And you need energy for this. You have to climb actively. This is called active transport, going against the gradient, going from low to high. So this is active type of transport. What is your primary source of energy? If you break your own ATP, get your own source of energy. So that is called primary active transport. So if you break your own ATP by the help of ATPase, all ATPases are primary active transport. What is secondary active transport? You want to climb the mountain, but you are so lazy to break your own ATP. So what you do, there is already your friend who is climbing the mountain. You just climb on top of your friend. Now both of you are climbing the mountain. This is also active, but you are not using your own energy, your own ATP you are not using. You are using your friend's energy. You are dependent on your friend. Most of the time the friend is sodium. Along with sodium, if some other substance is transported, this is called secondary active transport. There are two types of secondary active transport. So this could be in the same direction. If sodium and the substance are transported in the same direction, this is called symporter. Example, sodium iodide symporter in the thyroid gland. SGLT, sodium glucose transporter in intestines and kidneys. If sodium and the substance go in same direction, it's a symporter. If sodium and the substance go in opposite direction, it's an exchanger. It's called antiporter. Example, sodium hydrogen exchanger, sodium calcium exchanger. All these are antiports. This is active transport. What is passive transport? Now you are already on top of the hill. You just want to come down along the gradient. You just come from high to low along the gradient. You don't use any energy. This is called passive transport. There are three types of passive transport. Simple diffusion. What is simple diffusion? Oxygen and carbon dioxide use simple diffusion. Simply you lie down there and like a sliding board, if you just come down like that, that is simple diffusion. Simply if you come down, that is simple diffusion. What is facilitated diffusion? If there is a bus on top, if the bus is going to carry you down, bus is going to facilitate your transport. Facilitate means it is going to help you in your transport. So if there is a facilitator who is going to carry you, if there is a carrier protein who is going to carry you, that is facilitated diffusion. It has a Tmax. The problem here is a bus can hold a maximum of 50 people. If you are the 51st member on the queue, there is no place for you. It has already reached the Tmax. So it will get saturated. So Tmax and saturation are followed by facilitated diffusion. Example, GLUT transporter, glucose transporter, GLUT. Urea transporter, UT, urea transporter. All these are facilitated diffusion. Osmosis for water. Water can simply go across membrane or it can use the transporter aquaporin. Water channels called aquaporin. Non-ionic diffusion. This is not for ions but for weak acids and base like salicylic acids, ammonia. Salicylic acid is a weak acid, ammonia is a weak base. All these are transported by non-ionic diffusion. This is also a type of passive transport. So that was about the different types of transport mechanisms. Now over to the question. Which of the following is true about secondary active transport? Does not require active transport? Wrong. It's an active transport. Allows only co-transport? No. It will also allow symport. It's a type of facilitated transport? No. It's a type of active transport. Transport of one molecule dependent on the other? Yes. Sodium. Sodium is the main factor. Question number 6. A substance which travel down its concentration gradient. Yes, just now we saw facilitated diffusion. So the question is about passive transport. Which is the passive transport here? Facilitated diffusion. GLUT and urea transporter. Question number 7. Antigen present in all ABO blood groups is. So what about the blood grouping systems? According to ABO blood grouping system, there are different types of blood groups. All of us have this common antigen, H antigen on your RBC, all ABO blood groups. If you have the enzyme which converts H into A, you are A blood group. If you have the enzyme which converts H into B, you are B blood group. If you have both the enzymes, you are AB blood group. If you don't have both the enzymes, then you become O blood group. You don't have A antigen, you don't have B antigen, you have only H antigen, that is O blood group. What is Landsteiner's law? If you have any antigen on your RBC, for example, AB blood group person has A antigen, B antigen and H antigen. If you have any antigen, the corresponding antibody will be absent in your plasma. So AB group person will not have A antibody, B antibody and H antibody. This is Landsteiner's first law. What is Landsteiner's second law? If any antigen, or let's say if any antigen is absent on the RBC, then the corresponding antibody can be present. Let's take O blood group. They don't have A antigen, they don't have B antigen. So they can have both the antibodies, anti-A and anti-B antibodies. What is the rule here? If you have the same antigen, same antibody at any point of time, they will agglutinate and this will result in agglutination reaction, hemolysis. So same antigen, same antibody cannot be present. So antigen present in all ABO blood group is H antigen. Which is that blood group which does not have this H antigen also? Yes, it is Bombay blood group. Question number 8. Which is not a respiratory neuron? Dorsal respiratory group is a respiratory neuron. Ventral also is a respiratory neuron. Pneumotaxic center. This is also a respiratory neuron. Caudal ventrolateral medulla. This is not a respiratory neuron. So a word about the different types of respiratory control mechanisms. Your brain has the overall control of respiration. What are the centers in the brain? There are pontine centers and medullary centers. In pons, there are upper pons has pneumotaxic center, lower pons has apneustic center. In medulla, you have the dorsal respiratory group and the ventral respiratory group. We have the pre-Bodzinger complex also in the medulla. Now, what are the functions of these? Let's first learn the medullary centers. Pre-Bodzinger complex. This is called the pacemaker for breathing because it is the first rhythm for respiration produced from pre-Bodzinger complex. This is like the SA note. That's why pacemaker. And any abnormality in the pre-Bodzinger complex, pacemaker, there is something wrong in the pacemaker, this results in Ondine's curse. Dorsal respiratory group, DRG, responsible for inspiration. Ventral respiratory group for expiration, not normal expiration. For forced expiration only you need ventral respiratory group. So the mnemonic is DIVE, D-I-V-E. Dorsal respiratory group, inspiration. Ventral respiratory group, expiration. That's the mnemonic DIVE, D-I-V-E. Dorsal for inspiration, ventral for expiration. Pons. What are the centers in pons? Pneumotaxic center, apneustic center. Pneumotaxic center in the upper pons. This is the switch between inspiration and expiration. If there is something wrong in this switch, you don't know when to stop doing inspiration and when to do expiration. You don't know when to stop inspiration. So when you keep on doing inspiration, breathing becomes very slow breathing. When you breathe very slowly, tidal volume increases. So any damage to pneumothoracic center results in slow breathing, increase in tidal volume. Apneustic center. This helps to prolong inspiration. It can also cause apnea. What is apnea? Temporary cessation of breathing is called apnea. So back to the question. So we know that A, B and C are respiratory neurons, but D is not a respiratory neuron. Question number 9. Fraction of EDV. EDV means end diastolic volume ejected with every stroke is called as ejection fraction. So let's do a small calculation for ejection fraction. Normally in the cardiac cycle diagram, if you see, when the heart is fully filled with blood, this will denote 130 ml, which is called end diastolic volume. At the end of diastole, when your heart is fully filled with blood, this can hold 130 ml. So end diastolic volume is 130 ml. But nobody's heart can push out all the 130 ml. Any normal heart can push out only around 80 ml during every beat. It means every time your heart is striking, during every strike of the heart, every stroke, 80 ml comes out. That's why 80 ml is called as stroke volume. After pumping out 80 ml, how much is remaining inside? 130 minus 80, which is 50 ml. So at the end of systole, after pushing out 80 ml, 50 ml is still remaining inside. That's why it is called end systolic volume, 50 ml. What is this ejection fraction? Out of the 130 ml filled in the heart, what fraction was ejected? Only 80 ml was ejected. So you take a ratio of 80 by 130. 80 is stroke volume. 130 is end diastolic volume. So stroke volume divided by end diastolic volume is 60%. So any normal heart can eject 60% of the blood. If your heart is not able to eject 60%, if ejection fraction falls less than 60%, this results in heart failure. So fraction of end diastolic volume which was ejected with every stroke. It means fraction of stroke volume divided by end diastolic volume is ejection fraction. Over to question number 10. Infinite feedback gain is seen in renal output. What is this gain? If you want to assess the efficiency of any functioning control system, we can calculate gain of the system. The formula to calculate gain is correction divided by error. How much that system has corrected divided by how much error that system has left. So gain of a control system is correction divided by error. If error is 0, denominator becomes 0. Anything divided by 0 is infinity. So whenever the error is 0, it means if the system has left no error, it means infinity is the gain. It has done no mistake. So much is the gain. Infinite is the gain. Which is that system which will have an error of 0 and therefore a gain of infinity? Renal regulation of BP. When your kidneys are involved in regulating blood pressure, then it leaves no error. Error is 0. If error is 0, then gain of the system becomes infinite. So infinite feedback gain is seen in renal output. When your kidneys are regulating your blood pressure, it's an infinite feedback system. Question number 11. Maximum reabsorption of water takes place in which part of the nephron? Not only water. Maximum reabsorption of water, sodium, potassium and chloride. So major salts and water, major solvent, both are maximally reabsorbed from the proximal convoluted tubule. Around 60 to 65% reabsorption of major salts and water takes place in the proximal convoluted tubule, PCT. Question number 12. Aldosterone, site of action is aldosterone. High important topic both for NEET as well as INI-CET. Aldosterone is a hormone produced by the adrenal cortex. It acts on collecting duct and distal convoluted tubule. Aldosterone is called as salt hormone because The main function of aldosterone is to enhance salt reabsorption in the kidneys, and the main channel on which it acts on is ENaC, epithelial sodium channel, to increase salt reabsorption. That's why it is called as a salt hormone. So it mainly acts on collecting duct and the distal convoluted tubule. Question number 13. Macular densa is a part of, let me show you the functional anatomy of the nephron first. So this is the glomerulus from which proximal convoluted tubule arises. This continues as a loop of Henle. Loop of Henle has a descending limb and an ascending limb. Ascending limb, the later portions are thick. So it's called as the thick ascending limb. The thick ascending limb continues as the distal convoluted tubule. The distal convoluted tubule. This is the DCT. So exactly at this junction between the thick ascending limb and the distal convoluted tubule, there are special cells called macula densa. So where is this macula densa? At the junction between thick ascending limb and the DCT, or I can say it is present in the last part of the thick ascending limb or in the first part of the DCT. Both are correct. It is present at the junction between thick ascending limb and the distal convoluted tubule. Macula densa. This is the anatomy of these cells. So macula densa is a part of, yes, it's present on the first part of the distal convoluted tubule, or the junction between thick ascending limb and the DCT. So here we can go with distal convoluted tubule. Over to question number 14. A neurologist suspects cerebellar disorder in a patient. So there's something wrong with the cerebellum. Which of the following features would he not expect in this patient? So which is not present in cerebellar disease? Nystagmus, yes, we already saw it's a feature of cerebellar disease. Rebound phenomena, yes. Incoordination, yes. Ataxia. Resting tremor is not seen in cerebellar disease. Resting tremor is a feature of Parkinson's disease, which is a disorder of basal ganglia. So resting tremor is seen in basal ganglia disorder, not in cerebellar disorder. In cerebellar disorder, you see tremor, but it is intentional tremor. It is not resting tremor. It is intentional tremor. Intentionally, when you want to do any activity, there is tremor. This is called intentional tremor. Question number 15. Which of the following denotes compliance curve of a patient with emphysema? What is compliance? The ability to stretch. You put some air into a balloon. The balloon is stretching. So when the balloon stretches, that is called compliance. The more compliant the balloon is, more it will stretch. The less compliant the balloon is, it will not stretch. So what is compliance? If I put some pressure into the balloon, the volume of the balloon increases. The change in volume for the change in pressure. This is called compliance. That is why the compliance curve also has volume on y-axis and pressure on x-axis. That's the compliance curve. The curve B, the black one, denotes a normal curve. Let's take any pressure value, 10 centimeter of water. For this 10 centimeter of water pressure, normally the change in volume is around 5 liters. This is normal compliance. In fibrosis, what is fibrosis? Fibrosis is a condition where the lung tissue has been thickened or scarred. There's a scar tissue. When there's a scar tissue, you put some pressure into this. Let's say there's a balloon which is very thickened. More thicker the balloon is, the more harder you try to put air into it, it will not stretch. It's very difficult because a fibrosed lung cannot stretch. There's scar tissue, it cannot stretch. So even if you apply the same 10 centimeter of water pressure, 5 liter is not the volume change. Only 2 liter is the volume change. It means compliance has decreased in fibrosis. For the same pressure, the change in volume has decreased. So fibrosis lung will have decreased compliance. What is emphysema? Emphysema is a condition where all the individual alveolar walls, the septa, are all damaged. So all the alveoli, they join to form one big sac which can expand very well. So now when you try to put some air into this, because all the septa are all damaged, it will try to expand very well. For the same 10 centimeter of water pressure in an emphysematous lung, the change in volume will be around 8 liters. It means compliance has increased in emphysema. So which of the curve denotes compliance curve of patient with emphysema? So wherever the compliance is more, that is the emphysema curve. So curve C is the emphysematous curve. Yes, with that note, life is so beautiful. We end this session on most important PYQs for physiology for the upcoming examinations. I wish all of you all the very best to get the post-graduation of your choice and enjoy your life as much as possible. Let this 2025 bring in all happiness into your lives. Thank you so much for joining with me in this session. Thank you.